Good morning. My name is Gerard Hannibal. Over the next 10 minutes, I will be presenting an overview of the use of computer-based clinical decision support in medicine. This program was designed specifically for the use of GWU students enrolled in the Healthcare Information and Quality Outcomes class, spring of 2011. The objectives for this presentation are outlined in the syllabus available on this week's discussion board. In this presentation, I will attempt to answer 4 questions related to computer-based clinical decision support. What is it? Why do we need it? Does it work? And how do we get physicians to use it? The first question is, what is it? You may be surprised to hear that we all use computerized decision support every day of our lives. For example, if you have used spell check in MS Word today, then you have used computerized decision support. Your software detected a potential error and it then provided you with several alternate spellings. Perhaps you performed an internet search using Bing or Google, or even paid a bill by phone. You have used computerized decision support. Have you tried calling the airlines lately? If so, you were led through a maze of decision support programs before being allowed to talk to a real human being. Computer-based clinical decision support systems are broadly defined by the AHRQ as systems that provide clinicians with clinical knowledge to enhance patient care and patient safety. Clinical decision support provides clinicians, staff, patients, or other individuals with knowledge and person-specific information intelligently filtered or presented at appropriate times to enhance health and health care. I will mention expert systems here, but it is important to realize that expert systems differ from CDSS. Expert systems are self-contained programs that use artificial intelligence to model a decision that experts in the field might make. This presentation will not cover expert systems, but links to expert system sites have been provided in the syllabus for those of you who are interested in the topic. The types of information used in CDSS include passive and active referential information, alerts and reminders. These include adverse drug reactions, allergies, drug interactions, and laboratory results. Guidelines and scientific statements provide an important function in linking CDSS with evidence-based practice. CDSS can also include order sets, patient data sets, dashboards, documentation templates, and clinical workflow tools. Here's an example of a CDSS designed for the prevention of blood clots in a hospitalized patient. When the physician is entering admission orders, she is prompted to check off patient risk factors related to venous thromboembolism. Based on these risk factors, the patient is assigned a risk score by the program. Risk scores are linked to specific DVT prevention therapies such as subcutaneous heparin or sequential compression hose. The physician is prompted to click on the appropriate therapy and the order will be automatically placed. Now that we know what CDSS is, you might wonder, why do we need it? Clinical decision support is an important component of the computerized medical record and order entry system. The first reason that we need CDSS in medical care relates to the need for improving the overall quality of care. A landmark quality study by McGlynn and Associates, published in 2003, indicated that Americans receive only about half of recommended medical care. At the time of the study, only 24% of diabetics had their hemoglobin A1C tested. Hypertension and coronary disease patients only received 2/3 of recommended care. Only 64% of the elderly received pneumococcal vaccines. The second reason we need CDSS is for patient safety. We are all familiar with the landmark IOM report from 1999 on the impact of human error on safety and hospital death rates. Recent literature indicates that improvements in patient safety have been less than desirable since that year. In 2006, the Institute for Healthcare Improvement estimated that there were still 40 to 50 incidents of harm for every 100 hospital admissions. We still have a long way to go in the push for patient safety. Now we know what CDSS is, and we know we need it, but does it work? The answer to that question is maybe, and it depends. It depends on how the system is designed and administered. In a systematic review of studies looking at the efficacy of CDSS, Kawamoto and colleagues found that there are 4 independent predictors for success in CDSS. First, CDSS must serve as part of the physician's routine workflow. Second, the system must provide support at the time and location of decision making, for example, during the patient visit. Third, providing actual treatment recommendations works better than simply providing assessment support. Finally, use of a computerized system is an independent predictor of success. Systems that incorporate these 4 features have a greater chance of impacting both quality of care and patient safety. The fourth and final question in this presentation is, how do we get physicians to use CDSS? Developing a successful CDSS program that physicians will use is a time-consuming, iterative process. Bates and Associates studied the process and developed a list of 10 factors to consider when designing a CDSS. Each item informs some aspect of CDSS to make it more user-friendly or effective. The program should not slow physicians down, or they will become frustrated. The system should anticipate the user's needs and fit easily into the workflow. The system should make it easy for the physician to do the right thing. The designer should realize that physicians tend to strongly resist suggestions not to carry out an action if there is no other alternative ordered. CDSS can be used to encourage physicians to change their medication ordering habits by carefully manipulating the options available to them during the ordering process. When using clinical guidelines to guide practice, interventions should be limited to 1 screen. Data needed for implementing computerized guidelines should be limited to the least amount possible to avoid making the operator leave the station to look for information. Finally, systems analysts should carefully monitor use, get feedback, and keep knowledge-based systems up to date. For more details and specific examples, see the Bates manuscript in your syllabus. To summarize, today we looked at a brief overview of computer-based clinical decision support. We defined it and differentiated it from expert systems. We talked about why we need it, and I showed you some evidence supporting its effectiveness. Finally, we looked at some of the issues related to making such systems user-friendly. Now, it's time to hear from you. The first discussion board item offers you an opportunity to design your own innovation in computerized clinical decision support. The second offers a chance to debate the question of computer use in medicine. It has been a real pleasure working with all of you this semester. Your weekly presentation and discussion board activities have added value to this class, the kind of value that no textbook can provide. I look forward to working with you on the discussion board.